Cap Times Idea Fest 2020 is made possible by the generous support of our sponsors. Presenting sponsor, the Burrish Group at UBS, a financial services firm with global access and a local focus to pursue what matters most for its clients. Major sponsors are HealthX Ventures, backing entrepreneurs who are creating value with digital health solutions. Exact Sciences, pursuing earlier detections and life-changing answers in the fight against cancer. Quartz, health plans built with you in mind. And Madison Gas and Electric, your community energy company whose goal is net zero carbon electricity by 2050. Co-sponsors are Epic Systems and the Godfrey Kahn Law Firm. Other sponsors are Wisconsin Alumni Research Foundation, Home Savings Bank, Unity Point Health Moderator, Cargo Coffee, and the Forward Theater Company. Media partners are the Wisconsin State Journal and Madison.com, WKOW Channel 27, and Hinckley Productions. Please consider becoming a Cap Times member. Learn more at membership.captimes.com.
Hello, I'm Paul Fanland, editor and publisher of the Capital Times, and I'd like to welcome you to the Cap Times Idea Fest and this session featuring the CEOs of Madison's hospitals on how COVID-19 has and will change them. This is our fourth annual event, but the first that we're presenting virtually. Our theme this year is 2020 Changes Everything. Given the local and regional impact of COVID-19, the resulting economic damage and the impact of the Black Lives Matter movement, there's a lot to talk about. We think this year's lineup is our strongest yet. We believe IdeaFest has grown into a signature event on the Madison calendar. It is also an important showcase for the Cap Times, our locally owned and century-old journalism brand. If you're not already, we hope you'll consider becoming a Cap Times member. As a member, you'll have access to special IdeaFest programs, plus benefits throughout the year. You'll also be supporting an independent and trustworthy local media source at a time when that has never been more important. Learn more at membership.captimes.com. I'd like to thank the Burrish Group at UBS, which is the presenting sponsor of IdeaFest and has been with us since the start. Andy Burrish and Jason Moss have built their asset management firm's stellar reputation by effective investing for Madisonians, but also for investing in Madison. Their generous support of IdeaFest is but one example of their community commitment. The Burrish Group is the session sponsor of this conversation with Madison's healthcare CEOs. Again, thank you and welcome.
Hello and welcome to the Cap Times Ideas Fest panel, where I'll be talking with the hospital CEOs in Madison about the impact of COVID-19 on their operations. We have three CEOs with us here today. We have two remotely and one here in the studio. We have Damond Boatwright, who is the regional president of SSM Health in Wisconsin. And many people know that SSM Health includes St. Mary's Hospital in Madison, but you may not know that it also includes St. Mary's Hospital in Janesville and also St. Clair Hospital in Baraboo, along with many other services those organizations provide. And Damond is originally from Charleston, South Carolina. We also have Sue Erickson, also remotely. She is the CEO of Unity Point Health Moderator, and many people know Moderator for the hospital building near downtown Madison, but you may not know that Moderator also has a child and adolescent psychiatry hospital in Southwest Madison, and also an addiction treatment program and other kinds of services. And I believe Sue is from Iowa, but I may be wrong about that. She can correct us if I am. And she's been at Moderator for quite a long time, more than 30 years. And here in the studio, we have Alan Kaplan, who is CEO of UW Health. And many people know UW Health for the many buildings and clinics around the Madison area. But you may not know that UW Health also has a presence in Rockford, Illinois. It merged with Swedish American Hospital based in Rockford about 5 years ago or so. And Alan is from the Chicago suburbs. So we have lots of things to cover in terms of how the pandemic has affected local hospitals and local health care. To get us started, I wanted to ask each of you about your operations since February when the pandemic started. I know that you stopped offering many elective procedures in mid-March, and then I think in late April you resumed many of those procedures. You also restricted visitation, I think, in March, and then eased up on visitation over the summer. But then more recently, I think you've restricted visitors again. So I'd like you to just kind of give me an overview of, fill in some of the blanks. I gave a little bit of it, but kind of give me an overview of some of the steps that you've taken since February. And why don't we start with Damond?
Hey, thank you, David. I appreciate that. And thank you for allowing us the opportunity to come together for Ideas Fest and have this great sort of panel discussion. I'm with, and I have to say this first and foremost, I'm with two people that I have come to really respect and admire in Sue Erickson and Alan Kaplan. So it's always a joy for me to be on any kind of panel with them. Plus, the two of them make me look smarter than I am by their answers, by the way. So good seeing you, Sue, and good seeing you, Alan. So in terms of how this has impacted our business operations, this is going to come to no surprise, okay, to anybody sort of listening to this. But almost every aspect of our business operation has seen some change since February. We've sort of transitioned many of our support services, non-clinical personnel, administrative personnel to work from home. We've implemented screening processes, and Sue and Alan will sort of talk about this too, I'm sure, but we've implemented screening processes at the entrances of all of our facilities, hospitals, clinics, nursing homes, and reduced all facilities to a limited number of entrances with the screening process in place so we can sort of manage and monitor that more closely. Our clinical staff continue to abide by CDC recommendations when it comes to PPE use. I will say in terms of PPE use in the very beginning, at least for us, SSM in Wisconsin, we had to sort of scrounge around in the beginning and work sort of meticulously to make sure that we had enough PPE. I want to give a little shout out to the Wisconsin businesses that really stepped up here locally and manufactured more PPE, as well as our business partners and vendors nationally and even internationally who came through for us and supplied us with enough PPE. So today I stand here looking at having seen a warehouse that's here in Wisconsin that we have enough gowns and gloves and masks, I think, sufficient to get through what I hope to be a manageable surge. But operationally and practically speaking, all of these measures that we sort of put in place adds time and in many cases additional processes so that people can work. And then finally, for our administrative and support personnel, we no longer meet in person like we used to. It's sort of like this, David. We try our best to transition most, if not all, meetings to a virtual setting. And those are just sort of a few examples, and I'll sort of turn it back over to you.
Okay, how about Sue?
I wanted to thank David for inviting us to the Idea Fest. We're excited to be here. I also wanted to thank Damond and Alan for all of the work over the last several months. Our organizations have done a great job at working collaboratively within the community to really, as we've made adjustments and changes, to do that in unison to try to help with confusion and come forward with one voice to the community. I think that has served this city well. That's the first thing that I wanted to just raise up. What kind of organizational impact has COVID had? The thing I've been amazed about is how rapidly healthcare can change and adjust, sometimes as quickly as overnight, that we've had to make adjustments and changes on how our operations are working, especially early on in the pandemic. So healthcare is notoriously considered sluggish, and I think we've proven to ourselves that we can work rapidly when we need to, and we've learned how to do that very well. Most of the changes that Damond spoke to are the same changes that Moderator has made. I would say A lot of our folks are working virtually. 10% of our Meritor-based staff we've pushed out to working from home, and about 95% of our corporate-based staff, I would say, are working from home, and I would think the majority of that will stick. Visitor policies, we've really taken control of who's visiting our organization, shut down entrances, really managing visitors, minimizing visitors where we can. We know visitors are important to our patients, but also to help control the pandemic and keep our staff safe. We've really minimized how many visitors are allowed into the hospital. So those would be a few things that I would add that have changed for our operations.
Okay, Alan?
Yeah, so I echo my colleagues in thanking everyone for the invitation to be together, and with Damond, with Sue, and for the community. We always work together, the three of us, when it's for the community good, and we've worked together through the pandemic. So when we started realizing what was going to happen back in January, February, all of us started to take control of our organizations, connect with CDC guidelines. And there's a lot that's happened in the last 7 months. We didn't know back in February and March how the virus spread. We didn't know how to best treat it. We didn't have adequate PPE. We didn't have policies and procedures to keep our staff, our providers, and our patients safe. We didn't have testing capabilities. We didn't have off-site testing sites. All of this has been stood up in the last 7 months. All of us had to retool our facilities to create more ICU capacity, reverse flow rooms. So there's been a tremendous lift in the last 7 months. And through that, we are now back to functioning for all illnesses and injuries, all of us, all three of us, and we're doing it safely. The hospital's a safe place to be for our staff. It's a safe place to be for patients. And I'm sure you're going to get into it, but all of us had financial burdens that have been a result of the pandemic. So I'll just stop there and let you continue with questioning.
Thank you for the segue. I was going to ask about finances next. I have a few questions about the financial situation, but to start with, and I guess I want to recognize that all of your enterprises are nonprofits, but healthcare is a business in some ways, much like any other business, and you need revenue and you have to think about your bottom line. So each of your organizations, I think it was mid to late April, announced some cuts, including some pay cuts or furloughs and the like. Talk a little bit about exactly what steps you took then, why you felt you needed to take those, and what the situation is now, whether those things are still ongoing or whether they've finished. And maybe we'll start with you, Alan.
Sure. So you mentioned that we're non-for-profits, which is true, which means we don't have stockholders, we don't have shareholders, we don't give profits to individuals. All expenses are paid for by our revenues. That's payroll, so that we can provide jobs. It's our supplies, our medications, replacement facilities, technologies, all those things we need to take care of our patients in our community. And all of us target relatively small margins, anywhere from 3 to 4%, with the idea that's what we need to replace facilities and stay relevant and sustainable over time. When the pandemic began and we didn't have adequate PPE and we didn't have policy and procedures and we need to retool our facilities, we followed CDC guidelines and we stopped doing elective procedures, and we basically emptied out a good portion of our facilities, and we put a lot of investment into, as Damond said, scrounging for PPE, turning manufacturing to help us, putting in the policies and procedures, doing all these things. When we emptied the hospitals at UW Health, we decreased our monthly revenue starting in the second half of March to approximately $100 million less revenue per month. And so we knew that we were heading for a tough financial year. We had to put measures in place, not to reverse back to a full margin, but to mitigate the losses. And so we did things like compensation decreases, like flexing staff, stopping consulting engagements where possible, limiting supplies, but at the same time, costs were going up. We were paying more for PPE and we needed more quantity of PPE. We were investing in our facilities. We were investing in new signage and policies and procedures and ways to help social distance. We were putting a lot of communications into the community. As you know, daily, we are in the community trying to bring an element of truth as to what's going on in the pandemic and how to understand the virus and its effects. So for all of us, we took revenue hits, expenses went up, and then all of us had to take measures to reduce those expenses, not to reverse back to a margin, but to mitigate the losses.
Okay. Sue, why don't you share what Moderator did?
Yeah, all of what Alan described were things that Moderator did, as well as all of Unity Point Health. We did work, to give you an example, our hospital typically runs 280, 290 patients in beds, and at peak, we were down to about 140 patients in our beds. Really stopped production in our ORs to only emergent cases. Our clinics were down significantly, moving many patients to virtual care. As we were retraining the workforce to look for a surge. As it became apparent the surge was not coming at that point, we also realized that we were seeing a significant financial hit, and we did exactly as Alan said, we did across the board pay cuts for executives, for physicians, furloughing staff where we didn't have work, running staff to patients, the bedside staff to patients, and some FTE cuts. Since that time, we have resumed back to 100% plus work in our clinics as well as in the hospital. All of those measures have been reversed, and we're just kind of working forward as we watch what happens.
Okay, so just to clarify for both of your organizations, the pay cuts are no longer in place and the position cuts have been restored? Is that what you're saying?
I will give you one. There are some areas that look different than they looked prior to COVID. So there have been a couple areas in our organization where we've needed to right-size staffing to what is the going forward structure of our organization, but not significant cuts.
Okay. Is that also, are you sort of back to where you were, or?
Yeah, so we all executives took 20% pay cuts, physicians 15%, and when management in the area around 10%, and then our staff was flexed to the degree that we had work to do. And the pay cuts have been reversed, so it's back to normal pay. And the executives also there was no bonus payouts at all for the last fiscal year, which ended June 30th. The flexing, so we're very busy right now. So flexing is greatly diminished, but as Sue stated, and I could see Damond shaking his head yes in the background, all of us have areas that are less busy than they were, and that flexing would still continue in those areas.
Okay. Well, Damond, maybe you can talk about SSM and maybe talk a little bit more about the areas where the flexing is still down because of the volume being down.
Well, David, actually, I wanted you to keep all the attention and focus to Sue and Alan on this question. I thought you were doing a great job going back and forth there. All jokes aside, what I want your listeners to really understand is that all three health systems did very similar, if not identical, steps and activities to shore up our finances. Similar, if not identical. And then if you go beyond our three health systems and you look across the state of Wisconsin, many of those same hospital and health systems did the exact same activities that were well articulated by both Alan and Sue. And then nationally, that was the same as well. So I just want everybody to understand that first. And for SSM, yes, it had a significant impact on our finances. Now, when we say significant, I mean tens of millions of dollars of losses, not we didn't make budget, but tens of millions of dollars of being in the red. That is not sustainable for us to continue our mission and what we need to do to take care of our patients and the communities that we serve. So, yes, we too had to make very difficult choices. I'm not going to reiterate it. It's many of the same activities that both Sue and Alan eloquently talked about a little bit earlier. But primarily that came as a result of suspending elective surgeries and procedures that we started to restore back in May. Now, to offset those losses, we made cost reduction decisions. Many of those have been restored now at this point, but we also found ways in which we needed to be more efficient moving forward so that we can have a sustainable model. So we can ensure the safety and the health of our staff, our patients, as well as our community. Now that we've resumed many of those services that were suspended, and we've taken people off of furlough. So our folks were on furlough for about 13, 14 weeks, David. They were on furlough beginning in May all the way up until the end of July. So it was about a 13-week period they were on furlough. Now that we resumed our services, brought people back from furlough, one of the things I do want to mention, though, is we provided a return to work payment for those that were on furlough. So it was intended to cover any differences in their earnings between their normal pay and unemployment benefits that many people were eligible for, and any gap in pay that was lost during that time. And so now that we sort of back up and running with normal services, now we're looking to stabilize ourselves as we now look in front of what is probably our fourth surge. I think people have called it in Wisconsin, but this one will probably be the greatest of the surges because it's now coupled with beginning of the flu season and what's upper respiratory and GI illnesses that always take place in the winter.
I hope you're right that it's the greatest surge in the fact that we won't have a larger one afterward. So I guess also related to the financial picture, there was money, federal aid made available through the CARES Act. My understanding is that Wisconsin hospitals got about $1 billion collectively directly through some federal payments, and then the $2 billion that's come to the state to use as a discretionary fund, the governor has allocated about $40 million that will go to hospitals. So I'm interested in knowing how much of either pot or both pots each of your organizations is getting, what you used it for, and why you still felt you needed to take those cuts even with this federal aid coming. Maybe we'll start with Sue on this one.
Yeah, so I would say that obviously the CARES money was helpful. The road to recovery is multi-year. The CARES money that is forgivable or part of a grant for Moderator was about 10 million. Nowhere near comes near the losses that were sustained. The rest of the money came to us in the form of a loan that has a payment plan to pay back. So I think the take-home message there is we very much appreciate the CARES money. The grant money helps with cash flow. The 10 million helps some with a small increment of the losses, but we're talking about a multi-year recovery plan for hospitals all across the country, and the dollars, don't stretch to the gap that we see.
Okay. Damond, how about at SSM?
So David, I'll unabashedly say this, it was helpful, but insufficient to close the gap completely on the losses. And so I would say, depending on, again, it depends on what month you're in and your financial situation, where we were faced with tens of millions of dollars in losses. The CARES Act money, PPP, as well as other grant money, probably represented about 40% of what we could claw our way back from those losses, but we still had a hole basically that we had to fill, which is why we took all of the different measures that we did to get ourselves back above break even. But it was helpful, but it was insufficient to really close the gap completely for us.
And how much did SSM Health in Wisconsin get through that, through those avenues?
So it was, Sue said 10 million. I think for us, it was probably closer to about 25 million that we received back all the funding. But I want to say this too, and Sue and Alan can both sort of talk about this if they wish, but some of the most recent clarification and guidance that we're receiving around some of the funding itself, it is not clear whether or not it's going to be sort of a grant that does not have to be paid back, or it's going to be tied to a loan that we will have to pay back. Now, that nuance is significant in terms of profit and loss that we can actually bank, right? And so I wish I can tell you that the number is what the number is going to be moving forward, but again, there's still some confusion. Not confusion. I guess there's some guidance out there that suggest that the money isn't really ours to keep, all of it anyway, and we may have to pay that back.
Okay. Alan, what about the CARES Act money at UW Health?
Yes, so we received approximately 22 million in Rockford and 57 million in Madison, UW Health Madison. And I would echo what my colleagues have said. So we're a larger organization, so therefore we had bigger revenue losses and bigger CARES Act money. And if we were losing 100 million in revenues a month, in the first month we didn't decrease expenses. Actually, they went up as we're retooling facilities. That's what we used the money for. Retooling facilities, making facilities that weren't for inpatient to inpatient, or that weren't ICU to ICU. That's very expensive. We were paying a premium for PPE. We were buying more quantities of it. We're retooling the organization. We did not cut compensation in the first month of the drop in revenue. We were looking at, even with the CARES Act money, some significant losses. And even with the compensation cuts and flexing that we did and other measures to reduce expenses and mitigate some of the increased expenses and revenue losses, we still did not make up the difference. So these sound like large numbers, CARES Act money, but it really is exactly as Damond and Sue say. We appreciate it, it was helpful, but it did not reverse the losses.
Okay. Well, thank you. And this is sort of a financial question, but it's really more of an employee question. I wanted to talk about the impact of all of this on healthcare workers in your organizations. And some workers, especially early on in the pandemic, were a little outspoken about some of the working conditions, feeling they weren't always safe, they may not have had enough PPE. There seems to be a little bit less speaking out about that in recent months. But in general, especially nurses, Alan, as you know, obviously nurses at UW have tried to reorganize a union and spoken out about working conditions even before the pandemic. So I guess what my question is, what was the impact of the cuts back in April on your workforce and the morale, and how do you feel you've managed that since then, and how would you characterize the morale now? Start with you.
So thanks, and it's a big question, and we could spend a lot of time on that question and dialogue quite a bit about it. From the start of the pandemic, the number one concern of the organization and my personal concern was the safety of our staff. Of course, our patients, but we were very worried about our staff because if our staff weren't safe, one, it's our job to keep them safe, but two, then they're not there to take care of patients. And so we did everything we could to secure, to manufacture, to buy PPE, to put policies and procedures in place, to create safety protocols, guidelines. We put our infectious disease experts and our public health experts to work. We followed the CDC. We did all those things with the sole goal of keeping people safe. And I can tell you that the number of infections, COVID positive infections amongst our staff, despite that we test more than does the general public, our rates of infection are at or below the community acquired rate. We also, when we have infections, we do contact tracing behind the scenes. Now, we can't publicly say which staff member has COVID, but we can do contact tracing. We talk to the contacts. We do a lot of education on proper PPE use and all those things. When the pandemic hit, people are naturally stressed. Some of that's work-related. A lot of it's not. We have kids schooling at home. We have closed daycare. We have spouses losing jobs. And just the fear of the pandemic and the confusion nationally, all those things going on around us. Someone might have an elderly person at home. And early on, when you didn't understand the virus, the fear of taking the virus from work and spreading it through your family, especially if you have a multi-generational home, is very difficult for everybody. One of the things we did is we removed learners, residents, and medical students from the floors so they didn't burn through the PPE or be extra people to spread or catch virus early on. We do have learners back on the floors now. And of course, the visitors. When we went into the compensation cuts, like Moderator and like SSM, we led with executive pay cuts to say, hey, we're all in this together. All of us are in this together, and the executives took the deepest pay cuts. Now, having said that, the hourly staff were flexed, and when you flex, that could be minimal in an area that's very busy. It could be deeper cuts than the executives if it's an area that has no patients. So I don't want to hide that fact. That is a fact. And we did things like our lowest paid employees, less than $18 an hour, the executives contributed, as did many community members, to a fund to give them extra bonus money to help them pay their rent and help them through this. The other thing that we did is we didn't know how we're very busy now, so we're actually have the reverse problem. We went from flexing to a lot of overtime, which is stressful for people too, especially when their kids are at home and the daycare is tough. We did open up daycares. We are trying to help match people with home sitters and so forth. So we're doing a lot of things. I personally went to the floors with the COVID positive patients and to the emergency department during the early parts of the pandemic to talk with our staff, to ask them, do you feel you have adequate PPE? Are we giving you enough education so you understand what it is we need to do? Do you feel supported? And I never heard anything but the answer yes when I did rounds, and I did quite a few rounds on those areas. So it's a long answer. And we could keep going. I will also say that we told our staff there was no guarantee for any raises this year because of the financial conditions. We had 2 good months, July and August, that had positive margins. We told our staff that we are doing a compensation increase, a pay increase this year. We've reversed that decision based on our performance. So the first positive dollars that come back, we're giving back to our workforce.
Okay, thank you. Sue, what about the workforce at Meritor?
Yeah, I would echo a lot of what Alan said. Our supply chain is wrapped into the university supply chain. And I would say that what Madison had that maybe New York and Seattle didn't have was time. As we moved patients out of the hospital, our staff had smaller numbers of patients to deal with and to learn how to take care of, how to cohort, and the rapid response in Madison to PPE shortages, getting at extra protective gear. I was impressed with where we were able to get, certainly compared to my colleagues down in Iowa and Illinois, so felt good about the protection we were able to get to our teams fairly rapidly, as well as then knowing what kind of patient was coming in through our ability to screen, to do testing. That was a key component that helped us get patient populations to the right location in the hospital. But stress on our staff, absolutely. That is probably the thing that we spend a lot of time trying to understand how better to help our teams. All of the things that Alan said early on were prevalent on our campus. Now going forward, it is some of the uncertainty of schools, uncertainty of the financial situation, even across the country within their own families. We're spending a ton of time trying to be flexible with our staff's schedules, trying to understand, who can work remotely, and have better flexibility with their personal lives. So lots of time and effort there, and then trying to do listening sessions to understand how we better engage in this space, to minimize stresses where we can, doing things that we normally would have done as far as gatherings to get people together. We've done, outdoor movie theaters and things that we can help people gather safely, those sorts of things. But this is top of mind concern, I think, for not just healthcare, but I think all businesses across the country.
Damond, I assume the situation is similar at SSM, but maybe talk a little bit about it, and how would you characterize the morale now of workers?
Great question. Anxious. If I had to do one word, I would say there's anxiety that's out there, David, in all honesty. The pandemic has been very hard on everyone. Healthcare workers in particular, not just clinical staff, although they're right there on the front lines of this, but non-clinical support services and even management, as shocking as that is to say, it's been a strain on all of us. And all of this comes from the uncertainty that I won't reiterate that was talked about related to Sue and Alan's response. But I'll say this, I, like Alan and Sue, I'm sure, since March, I have been rounding in every single one of our clinics, and we have 72 of those, by the way, every single one of our hospitals, which we have 7, and our nursing homes. I've been physically rounding myself, polling and monitoring our staff, and asking them to report mental and emotional stress levels. You mentioned earlier, David, I'm glad you did that, some of our staff were vocal. You know what I've said to them? I want you to be vocal. I want you to continue to be vocal. All I ask is that you express those sentiments and comments in the right places so we can constructively work on solutions together. My call out to everybody listening, to be honest with you, regardless of your situation and where you work in your industry, now's the time for us not to be divided. Now's not the time for us to be pointing fingers back and forth. Now's not the time, to be honest with you, for second guessing. Now's the time to say, how do we collaboratively work together and find ways in which we can all heal and try to find some level of resiliency so that we can work through the next surges that are happening. So with us, we've looked at data about our employees themselves and their emotional status and their physical well-being. We've developed self-care resources that help employees connect with others, learn self-care techniques, access needed support, which, by the way, let me also say this to all your listeners. I'm using it myself, in all honesty. We've previously had established employee relief funds that provides emergency financial assistance to our employees facing unexpected financial hardship. I challenge my board, I challenge all of the administrators as well as the supervisors to fund that employee relief fund at record levels so that we can provide that financial assistance to our very own employees. We increased the maximum amount of assistance available to those employees and increased the number of times an employee could receive that support. And then as a healthcare organization, finally, as a Catholic healthcare organization, we've also implemented a weekly common prayer and reflection resource for interested participants. This standing meeting not only offers a way for our staff to connect virtually with their individual faith, but also connects with others. Believe it or not, it started out with just me and two other people that did this together, and now it's over 100 people who come together on a weekly basis just for meditation, reflection, and prayer, and centering ourselves and at least finding 15 minutes in that day where we can come together with one voice, one common set of issues, and say, we're going to get through this together.
All right, well, thank you, and we need to take a bit of a break.
Cap Times Idea Fest 2020 is made possible by the generous support of our sponsors. Presenting sponsor, the Burrish Group at UBS, a financial services firm with global access and a local focus to pursue what matters most for its clients. Major sponsors are HealthX Ventures, backing entrepreneurs who are creating value with digital health solutions. Exact Sciences, pursuing earlier detections and life-changing answers in the fight against cancer. Quartz, health plans built with you in mind. And Madison Gas and Electric, your community energy company whose goal is net zero carbon electricity by 2050. Co-sponsors are Epic Systems and the Godfrey Kahn Law Firm. Other sponsors are Wisconsin Alumni Research Foundation, Home Savings Bank, Unity Point Health Meritor, Cargo Coffee, and the Forward Theater Company. Media partners are the Wisconsin State Journal and Madison.com, WKOW Channel 27, and Hinckley Productions. Please consider becoming a Cap Times member. Learn more at membership.captimes.com.
Welcome back. Now I wanted to talk about the impact of COVID-19 on the delivery of healthcare at your organizations. I guess the main thing that I'm aware of is telehealth. I know that organizations that weren't using telehealth a lot really started to use it more in April or so when the federal government relaxed some of the rules involved. So I wanted to ask you about how you're using telehealth. Do you think that'll continue indefinitely, or might it go away after the pandemic? And how else has delivery of care changed at your organization? And let's start with Damond.
Okay, so in the beginning, thank you, David. In the beginning, we needed to make some adjustments clearly to when and where and how we were going to provide care. That became obvious very quickly with COVID-19. In our hospitals, we sort of immediately transitioned our patient rooms and full units into, and Alan intimated this, but into what they called negative pressure rooms, which is sort of a reverse flow room. And so we did that. We created plans and procedures for how we cohort the COVID-19 patients so we don't just have them spread throughout the hospital in various areas. And those that were suspected with cases of COVID, we sort of put them all in sort of quarantined areas, if you will. I mentioned we reduced the number of entrances and exits to reduce traffic flow and allow for screening of everyone who enters our facilities, including all staff, physicians, patients, support persons, including myself, by the way. And then we enacted visitor restrictions, as you know, that waxes and wanes depending on the number of COVID prevalence cases that we have. But for our outpatient services, and that's the question you asked about telehealth, for our outpatient services, we swiftly transitioned much care to telehealth. I think at the height of our telehealth offerings, if you will, which was in May, the end of May, we had about 85% of our visits were telehealth, and that equated to about 40,000 visits that we had on the clinic side. All were done, and that's just right here in Greater Dane County, if you will. All were done using telehealth. That platform was necessary. It was appropriate. We stood it up relatively quickly. We already had a foundation for telemedicine, telehealth to begin with, but standing it up and scaling it across all of our different clinics and all of our different specialty programs and primary care, that took a little bit of work, but we did that in pretty short order. That allowed us the ability to connect with our patients and provide them care when and where they needed it best. While we also resumed our elective surgeries and procedures, we've also implemented sort of pre-procedure testing protocols that come with that as well. And we've brought in our own type of testing so we can test for COVID patients and get turnaround times pretty quickly. Alan's been ahead of the curve. I'll give him credit for this. I mean, as an academic medical center, I think they always had the equipment. He can dispute me, but I think they've had the equipment for quite some time and was able to do a higher level of in-house testing and didn't require the testing capabilities of maybe private organizations. We use some private organizations like Exact Sciences and some other labs to help us, but now we have our own in-house testing capabilities, which really ramped up our ability to turn around, test, and do pre-procedure testing protocols to make sure that everybody is safe. And then finally, through our surge planning and collaboration with the other local and state health systems, we've been able to manage the number of COVID-19 cases that we have so far. And I feel pretty good as long as we don't find ourselves in a situation where the chain of infection gets too far outside of the relatively healthy 18 to 22 year range, and it gets into vulnerable populations, whether that be seniors or those with comorbidities or those that live in cohabitated situations that are on top of one another. That's when the spread happens very rapidly, that leads to higher levels of hospitalization and critical care challenges. But if it stays steady as it is, I think all the steps that we've put in place to provide for a telehealth mobile platform, as well as those that are most critical having to come into the hospital, my hope is that we're going to be able to manage through that as effectively as we can.
Just as a quick follow-up, if you were at 85% telehealth of outpatient visits in May, where would you be at now?
Oh, yeah. Thank you for asking that follow-up question, David. So this is my own opinion, by the way, my own opinion. So I guess it all depends on who you ask. But in my own opinion, it unfortunately has dropped to close anywhere between, it fluctuates, but anywhere between, David, 10 to 20%. It depends on the week. But the telehealth being received from our patients has dropped precipitously from where it used to be. Now, we have asked, just so you know, we ask every patient, would you like to have a sort of telehealth visit and telemedicine? And believe it or not, this is sort of surprising to me. It depends on the demographics. But many people have chosen to come back to the clinic itself physically versus using telemedicine. But I'm hoping to ramp that back up, because my belief, as a second part to your other question, my belief is that has to be the way forward for us to provide care and do it in a flexible, reasonable, and appropriate way. And I would ask us to relax the standards, but to change the standards to make it more conducive that telemedicine and telehealth becomes every day the way we do outpatient, non-emergent kind of screening and care where it's appropriate to do so.
Okay. Sue, tell us a little bit about how Moderator has adopted telehealth, how delivery of care has changed otherwise, And also, when we talk about telehealth, maybe talk a little bit about whether you're referring to phone visits or video visits, because I think it can include either.
Yeah, so with telehealth, I would say Meritor in our clinic setting peaked at about 40% of our visits were delivered through video visits or telehealth. We saw some significant positive outcomes for that in areas like our New Start Drug Abuse Center, where we were actually reaching patients, created more compliance with treatment plans, and also less no-shows. People were willing to pick up their phone and have a visit. So we saw that as a tremendous benefit now and going forward. The other place telehealth played a big role for us is in our child and adolescent psych facility, as we were looking at, there's a lot of group therapy that occurs in that setting. And with children being at home, we were using telehealth in some of our intensive outpatient care setting, which allowed us to reach children in their home versus bringing children into a facility. So another big benefit that we continue to expand on was able to give us another set of classes. Some of the things that have changed for us in lots of areas is because of social distancing and keeping folks safe. The size of therapy classes all across the board have had to shrink and stretch the hours of the day to do that, which obviously creates more strain on our labor pool to get that done, and obviously more cost for that kind of care. The other thing that was occurred in this time frame that we don't talk a lot about, but I think has a lot of benefit, is we've moved telehealth or the virtual visit into the hospital setting, into the patient room. We use that with some of our COVID patients, bringing virtual care of subspecialists to the patient without the subspecialist actually having to go into the room. And that helped minimize the number of people in contact with a COVID positive patient. So Damon raised up a lot of the same things that Meritor's doing. We have seen a fallback of telehealth. We will be continuing to pressure as organizations. We think telehealth, virtual care, whatever you want to call it, has a strong role in how we deliver healthcare in the future. But patients do like to see their physicians. Physicians do like to see their patients. But there is certainly a subset of visits that make sense to be done through virtual or telehealth.
Okay, thank you. And Alan, talk a little bit about telehealth at UW and how else delivery of care has changed.
Sure. So at the risk of being repetitive, I will try not to be too repetitive. Through our health plan, Quartz, we saw 2,800 televisits, virtual visits in 2019, in that calendar year. In just April alone of 2020, we saw 40,000 visits.
Wow.
So I just twist the statistic from percent of clinic visits to actually what we're seeing from a health plan perspective, exponential growth. Like Damon mentioned, it's now falling back. We do have people that want to come back to the clinics. A lot of people believe telehealth will fall back into that 15, 20, maybe aggressively 30% range, but I'm going to guess in that 15 to 20%. A lot of it will depend on whether the insurance companies and whether the government will continue to pay for those visits. Certainly today a lot of visits are not just Zoom type, not Zoom, but Zoom type visits, but many of them are phone calls too, and that will probably be rolled back. But that's been a great benefit for those that either don't have broadband or don't have technical capability or ability. The other thing that we learned is that we thought telehealth was good for minor illness in young individuals. We are finding those that are elderly and with chronic illness really take to the telehealth and enjoy it. It's much more convenient than getting dressed and driving to the doctor, parking, waiting in a waiting room, and all that process. So it's very efficient. we're also finding providers like it. And at a time when there's nationally significant provider burnout, this is a nice thing to offer to our providers and to our patients, of course. So just to add a different perspective, there was a time when I was a full-time practicing emergency physician, and when someone called our nurse triage and they had an upper respiratory infection, let's say they had a cough and a fever, I always felt, I'll see any patient, anytime, anywhere for anything, come on in, I'll take a look at you. When I look at today, we don't do that with suspected COVID patients. We do a phone visit or a virtual visit, and then we send them to an outpatient testing facility, keep them separated from the general healthy population. And I look back in time and I just say, some things can't be unlearned. Going forward, why would we take the chance of cross-infecting any infectious patient, COVID or otherwise, with patients that are not infected in the waiting rooms, in the clinics, our staff? And so I think that we will likely change the way we deliver health care to keep those with upper respiratory infections separate from the general population, COVID or otherwise. We may do it through telehealth. We may do it through specialized testing centers. We may do it other ways. But I think that's in that category of some things you learn you can't unlearn, and it's just a better way to practice.
Mm-hmm. Okay, that's interesting. So I want to talk a little bit about capacity at your organizations. We had a surge of patients in hospitals, COVID patients in hospitals here in Dane County and around the state in April, and then things kind of gradually went down for a while. And then obviously more recently in September and now in early October, we've seen an even larger surge, especially statewide, and more recently this week in Dane County. I think we have more than 50 COVID patients in hospitals in Dane County now, over the peak in April of 46. So I'm wondering, I've been told that capacity is, you can think of hospital capacity as space and staff and stuff, which I think means beds, workforce, and equipment. So I'm wondering how stressed those things have become at your hospitals, what steps you're taking to prepare for an even larger surge, and at what point would it become a crisis where you might need to use an overflow facility, for example. So Sue, why don't we start with you on this one?
Okay, so when you talk beds within Moderator and across the other facilities, I think that the bed capacity is not the limiting factor. We have not hit the ICU capacity. What's really, at least for sure in our organization, would be staffing to support significant increases. The way that we're looking at this as organizations, and we're in incident commands and communicating daily with each other around what are we seeing. We are peaked higher than we were early on, and we have small levers that we'll start to make adjustments on, which would be looking at elective procedures and backing some of them off. If you go back 4 months, we shut them off. We would be backing them off. That could be something like pulling out one of our cath labs and taking that staff and helping to take care of medical surgical patients. Instead of running 11 ORs, running 10 ORs, and taking that staffing and repositioning it. Taking some of our primary care physicians, limiting visits that are not emergent, and bringing some of that primary care physician population back into the hospital. We have levers and people cross-trained to different areas to kind of subtly turn things on and off. Right now, we've not had to do that, but we are watching what's going on in the community carefully, and are working on what those levers are. We have what's called progressive plans in that space of little incremental levers to give ourselves capacity.
As a follow-up, can you give me a sense of how many COVID patients you have at Meritor now? How many are in the ICU? And at what point would you start taking some of those levers?
Yes. So today we have 15 in our hospital. And I would say there's 2 that are in our IMC ICU capability. We have bed capability to 24 ICU beds. We typically run 12 to 14 ICU beds, and then we would rearrange some staffing to get at more capacity. Right now, the other shift we've seen with our COVID population, and we hope this continues, is we're seeing more general medical care COVID population than ICU, probably based on the fact that our folks have learned over time how to treat this patient population. Therapies have changed over time, and how we navigate and manage that patient population. So in Meritor, we would just use some incremental adjustments. But right now, most are in general care, and there are a couple in ICU.
Okay. Alan, can you talk about the situation at UW?
Yeah, so for all of us, we're always concerned about beds, but beds isn't the most urgent issue. It is staffing. And it's not just that all of healthcare nationally and locally suffer from labor shortages, but also we have the added burden that in the past, if a staff member had a cold, I'm not saying this was right, but they would still come to work. Or as soon as they were better, they would come to work. Today, if anyone has any symptoms, a cough, a cold, a runny nose, a sore throat, a headache, a fever, they can't come to work until we're able to test them negative for COVID. And so that takes a lot of people out of work. We also have stressors at home. Children aren't in school, daycare's closed. So people are either cutting back in hours or are less able to be flexible with their hours. And so I think that our biggest concern is staffing, just general staffing. You mentioned, staff, facilities, and
Stuff.
We got plenty of stuff.
PPE.
We have stuff.
Yeah.
And so PPE, we have a red, yellow, green light system that we give to the staff every day, and green light means we have 2 weeks of PPE on hand of that item. And it's a tough one to explain to people, because it's not just what do you have in stock, it's also the burn rate. So how much do we reuse PPE? We don't like to reuse it, but there's landfill issues, there's safety issues, and there's burn rate issues. And so we do reuse PPE based on CDC guidelines and guided by our infectious disease specialists. So you have a stocking rate, a burn rate, and then a utilization. How many people do you allow in? Learners, for instance, medical students, nursing students, and so forth. So we are constantly monitoring that to keep a minimum of 2 weeks supply, hopefully a lot more on hand.
And also in the category of equipment is ventilators. That doesn't seem to be as much of a concern as it was early on. Is that right?
Yeah, ventilators have not been a concern. We're not even close to reaching capacity. We have plans to repurpose and expand our ventilatory capabilities, but it's not a concern right now.
Okay. Damond, what's the situation at SSM Health?
Yep. So David, thank you for allowing me to sort of jump in here. And I want to, if you don't mind, I want to take it in the same direction, but I want to answer it differently, because truly Sue and Alan captured our situation really well right here in Dane County for the hospitals and the nursing homes that we have. But let me see if the two of them agree with this too. So here's what would help us though. My number one concern of all the concerns happens to be workforce availability and their stress level right now. That's my number one concern. And here's what can help us sort of work through this right now. If we're able to invest as a state using private companies and public-private collaboration and governmental to expand and enhance broadband access to our rural brothers and sisters so we can do a better job of having reliable continuity of coverage and signal availability so we can have telemedicine and telehealth propped up and available. That helps the workforce strain. If we can also find a way to have multi-state ease of restrictions on licensure of healthcare workers, and so people can go across state lines much easier and be able to just jump right into the fray and work in our hospitals where we have a workforce shortage in many cases, that would help us as well. As I mentioned earlier, continuing to ease the regulations around telehealth, telemedicine would be very effective to prop up that technology and to be able to offer clinical services even virtually to those that need it. And then I'd also dare say this too. One of the things that are challenging, about 20% of our workforce that have kids both in daycare or K through 12, finding a way so that we can keep our kids and our teachers safe, but opening up the schools so they can go to school. I have many nurses, and I know Alan and Sue have the same situation going on too, who say, I'm challenged. I'm challenged with the idea of, do I go to work so I can take care of the sick and those that are most vulnerable, or do I take care of my own children at home through virtual learning? And when you're at the age of 6 through 10, as much as we love our kids to be independent, they can't just stay at home by themselves and do that work. And so if we can find a way to make sure that we can do that, that would help. And then, and I know this is something that Alan's been always very passionate about, an investment in public health. We can do but so much in healthcare, and we have been trying to be sort of the substitute for an inadequate funding of public health. But many of the conditions that exist and the disparities of health outcomes that exist is by and large due to the environment and the conditions that people live in, and an inadequate investment in public health right now. And we can't continue, given the decrease in margins that we've talked about earlier on the hospital side, both fund the delivery of healthcare as well as public health initiatives at the same time. So if we can sort of do those things, this would help create a little bit more capacity and ability for us to deliver care in the way that we should for this crisis that we're in.
Well, that's great. And I think we're just about out of time. So I want to thank all three of you for coming together today and helping let the Madison community know how COVID has impacted your healthcare organizations. I appreciate it.
Cap Times Idea Fest 2020 is made possible by the generous support of our sponsors. Presenting sponsor, the Burrish Group at UBS, a financial services firm with global access and a local focus to pursue what matters most for its clients. Major sponsors are HealthX Ventures, backing entrepreneurs who are creating value with digital health solutions. Exact Sciences, pursuing earlier detections and life-changing answers in the fight against cancer. Quartz, health plans built with you in mind. And Madison Gas and Electric, your community energy company whose goal is net zero carbon electricity by 2050. Co-sponsors are Epic Systems and the Godfrey Kahn Law Firm. Other sponsors are Wisconsin Alumni Research Foundation, Home Savings Bank, Unity Point Health Moderator, Cargo Coffee, and the Forward Theater Company. Media partners are the Wisconsin State Journal and Madison.com, WKOW Channel 27, and Hinckley Productions. Please consider becoming a Cap Times member. Learn more at membership.captimes.com.